8 participants. That's not right.
We'll wait a couple minutes for everyone to join. We've got a larger group today than we typically do. The One Academy team has been growing, and so we're expecting some people who are interested in seeing how this sort of thing goes, how presenting the research at a journal club goes, and how presenting the specifically the One Academy nodes and things like that happen. So we're going to wait a couple minutes, I think, for everybody to jump on, and then we'll get started. We have a couple presentations today from some of the new One Academy team members, as well as some familiar faces. Ashley will be, or familiar voices, I guess. Ashley will be presenting, and we'll be talking about aerosol versus droplet transmission for SARS-CoV-2. Okay, so we're gonna get started with, I think, Amanda and Yeji, are you on? Looks like you are. So we will. So we'll get started. I don't know if one of you wants to share your screen or if you want to take turns. Everybody should be able to share their screen now. So.
Hi, sorry for the wait. My name is Amanda Sherwood. I'm a rising junior at the University of South Florida, and I'll be presenting along with Yeji, and I'll be sharing my screen momentarily. Okay. So just want to check, can everyone see my screen currently?
Yep, looks good.
Okay, perfect. So the way that this presentation is going to go is I'm first going to provide some background information on the respiratory particles, which are the subject of the debate today, which is the aerosol versus droplet debate. So as we all know, give me 1 second. Okay, perfect. So as we all know, SARS-CoV-2 is primarily transmitted from human to human by several means, namely by respiratory particles such as droplets and aerosols, and fomites. Apologies if I'm mispronouncing that, but they're inanimate objects that upon exposure to viral particles are able to transfer those particles to humans. These viral particles are often globs of mucus, saliva, and water, and the particles are differentiated based on their size and to a lesser extent their behavior in the air. And then we move on to what categorizes a droplet versus what categorizes an aerosol. So the larger globs, so to speak, are often too heavy to remain in the air, so they fall at a faster rate than they evaporate, and then thus they land on various surfaces. And these particles are generally referred to as droplets, and they're usually defined as having an aerodynamic diameter greater than 5 micrometers. And then aerosols are often the smaller particles that evaporate faster and travel farther, and they usually remain airborne for a prolonged period of time, and their aerodynamic diameter is often smaller than 5 micrometers. They're more susceptible to being inhaled and reaching the alveolar region of the lungs. And there are also cases where droplets evaporate and eventually become aerosol particles referred to as droplet nuclei. So this background information thus allows us to proceed to the aerosol versus droplet debate. And after I briefly explain this node, then I'll let Yeji take away the second part of the presentation. So this debate is essentially how SARS-CoV-2, like what primary means of transmission does SARS-CoV-2 employ? And right now, whether that's aerosol transmission or droplet transmission is not completely known. And determining this has critical implications, because if primarily spread via droplets, then masks, the distancing rule, and other preventative measures are moderately effective in preventing transmission. But if it's established that SARS-CoV-2 is primarily spread via aerosols, then preventative measures or existing preventative measures become less effective and thus need to be modified. And in order to modify them so that they properly work, the behavior of these particles needs to be examined at a greater detail. And examining the source of transmission for both types of respiratory particles are also crucial. So now I will stop sharing my screen and Yeji can take it away from here. Does anyone have any questions thus far? Okay, thank you. Let me stop here.
Hi, can everybody see the screen?
Yep, looks good.
Thank you. So thanks, Amanda. To continue our presentation, the sources of aerosol transmission include medical procedures, fast-running tap water, toilet flushes, sneezing, coughing, exhaling, and droplets that have evaporated to become droplet nuclei suspended in air. And as a child node of this parent node, I created examples of medical procedures that can cause aerosol transmissions. So those include endotracheal intubation, bronchoscopy, open suctioning, administration of nebulized treatment, manual ventilation before intubation, turning the patient to the prone position, disconnecting the patient from the ventilator, non-invasive positive pressure ventilation, tracheotomy, cardiopulmonary resuscitation. And so after that, we also created a child node explaining the aerosol versus droplet transmission via sneezing, coughing, and exhaling. And if I can just zoom in a bit. So as you can see, the turbulent gas cloud of buoyant aerosols, as well as the large droplets, can travel at least 6 meters away within 0.12 seconds after sneezing, and they can both travel at least 2 meters within 0.2 seconds after coughing, and travel for 1 meter within 1 second after exhaling. However, we can see, as expected, that the virus-laden aerosols are suspended in air for a longer period of time than the larger droplets. So I would be curious to know where these particles ended up after a long period of time to sort of demonstrate how far aerosols can travel under a certain condition that they placed for this experiment, but unfortunately they don't in this article. And moving on, we then can examine factors affecting aerosol droplet dispersion. And those include temperature, humidity, radiation from the sun, and open and closed space or ventilation. And this article that we were mainly focusing on talked about the effect of confined space on the virus-laden aerosol and droplet behavior. And those examples include cabin of airplane, interior space of car, dormitory type space of healthcare or isolation center. So first we could look at the behavior of those particles inside of a plane. And before we can look at that, if we wanted to find more information about the aerodynamics of airplane in general, we can look at the parent node, which is this one right here. And this just gives a brief explanation of aerodynamics in cabin airplane. And so I thought it was interesting that there is a filter that could remove 99% of 0.3 nanometer aerosols that can be removed from the plane. And going back to the topic, here they used computer modeling to predict that 5 to 10 people could get infected due to droplet spread with an infected person on board. Aerosol plumes may affect far more, but the extent to which aerosol plumes can infect susceptible hosts is still poorly understood. And moving on, we can then look at the aerosol droplet behavior in car interior space. So they give two models. The first model is a vehicle moving at a moderate speed. Unfortunately, they don't define the exact speed in the article, but this model has the AC on and the windows closed. And the cough jet from an infected person in the back seat can form droplets and a plume of aerosols with the average speed of 10 meters per second, ACH less than 60 per hour, temperature less than 25 degrees Celsius, relative humidity less than 50%. And the plume of aerosols first spread towards the front and then turns backwards as it gets carried away by the AC streamline. And then this sort of increases the risk of infecting everyone in the car. And to support this computer-generated model, the authors give an example of a case in Sri Lanka where an infected passenger sat at the back seat for less than an hour in a confined space with closed windows and AC on, and the driver was tested positive for that. And lastly, we could look at the aerosol and droplet behavior in hospital setting. So if we look here, model 2, the ceiling, this is the ceiling fan model, and the virus-laden particles sort of surround the infected person who just expelled a cough due to the localized ventilation. And by the process of convection, the hot air, including the virus particles, rises toward the ceiling. And open windows could help escape this hot air, which can decrease the risk of virus transmission. And on the other hand, model 1, the air is coming from one source and traveling back to the same source. And this diagram shows that a central AC system can somewhat increase the risk of transmission. There are 2 case studies that suggest that virus-laden aerosols in confined spaces with poor ventilation are more likely the cause of transmission. So the first case was in the United States. After about 9,000 healthcare workers tested positive for the virus by early April, and this massive rapid spread of the virus suggests that aerosol transmission is a serious threat whilst inquiring further research. And lastly, the transmission in healthcare center in China with 1,716 healthcare workers infected despite wearing PPE suggests that aerosol transmission played a greater role in such rapid spread of the virus. And finally, I will hand over the presentation to Amanda again. Thank you.
Once again, thank you, Yeji, for going into detail about the aerodynamic simulations of droplet and aerosol behavior in confined spaces. That was great. So to segue into safeguards against transmission of aerosols and droplets, after we have gone through the limited understanding of behavior of these particles, studying the generation and mobility of these particles are of the utmost importance in order to develop adequate safeguards. The improvement of these safeguards is crucial, especially for healthcare workers who are exposed to viral particles via patients infected with SARS-CoV-2. So then we have our different types of safeguards. So there are surgical masks, cloth masks, N95 respirators, disposable particulate respirators. These are more commonly used in Europe by healthcare workers, and elastomeric respirators. And then here are 2 graphics. These are graphics from another case study that was cited in the article. And this graphic is simulating the trajectory of droplets and aerosols from an infected person in the event of coughing. And this is done with different masks. So the N95 elastomeric, the N95 respirators and the elastomeric respirators appear to have the best, they're most effective in mitigating both aerosols and droplets. The surgical mask has moderate success in reducing droplet transmission, but because surgical masks are often quite loose at the sides, it allows for aerosol clouds to still escape at a significant rate. So it's less effective with limiting aerosol transmission. And then we look at a graphic from looking at transmission from an infected person to a susceptible host. So now this graphic attempts to simulate the trajectories of aerosol clouds and droplets expelled from an infected person to a susceptible host, and the ways that the various safeguards affect the amount of viral particles transmitted to the host. So the first graphic, we have the infected person is wearing no safeguards, as is the host. So risk of transmission is extremely high, very close to guaranteed in a real life situation. Then we move to having a susceptible host wear a surgical mask. So the transmission of droplets and aerosol particles is slightly less, but doesn't really do much in protecting the host. There's still a very high risk of transmission. We then see the best success with N95 respirators and elastomeric respirators. However, due to the short distance between the infected person and the host, risk for transmission is extremely high in all cases, especially since only one of the two people interacting in this simulation have safeguards present. This would obviously be better if the infected person also wore a mask. So lastly, we have the effectiveness of various safeguards. So the rapid growth of COVID-19 cases prompted a massive shortage in PPE, which drove the CDC to modify its guidelines on masks to include homemade masks or fabric masks. The success in preventing contact with aerosols or droplets varies and depends on the material, interwovenness of the mask, among other factors. 3 types of disposable particulate respirators, which I mentioned earlier, known as filtering face piece 1 or FFP1, FFP2, and FFP3 have been used by healthcare workers in Europe when working with infected patients. And FFP3 is reported to be the most effective in filtering particles with a minimum filtration of 99% and a maximum leakage of 2% to the inside of the mask. Other studies compared surgical masks, homemade masks, and FFP2 respirators, which have a minimum of 94% filtration and max 8% leakage. So even with the disposable particulate respirator that isn't the strongest in that category, it still widely outperforms surgical and homemade masks. I believe the statistics are that FFP2 masks provide 25 times the protection that surgical masks do and 50 times the protection that homemade masks do. And along with that, so this supports Yeji's earlier presentation regarding the behavior of viral particles in confined spaces. And the full image of those simulations also includes a version where the infected person is wearing a surgical mask or an N95 respirator or an elastomeric respirator. And along with the graphic shown here, where the N95 respirators and the elastomeric respirators have they're most effective against preventing transmission of aerosols and droplets. That's also shown in the aerodynamic simulations. So then the last part of the presentation will be introducing another article that's a lot shorter. And this is an article from the JAMA network. And it has to do with the aerosol versus droplet debate. And in this article, it was emphasized that while evidence surrounding SARS-CoV-2 behavior is circumstantial, as is with most of the literature, there should be more consideration of other modes of transmission and not just airborne transmission. So the first argument that they make is that if SARS-CoV-2 relied on primarily airborne transmission, then its reproductive number should be considerably high due to the increased difficulty of mitigating aerosol transmission with existing safeguards. So in this article, the R0 value was compared to the measles R0 value, which is another respiratory virus that actually relies mainly on airborne transmission. So measles R0 value is closer to 18, in contrast with SARS-CoV-2's relatively low R0 value, which I believe is roughly 2.5 to 3. And then the other argument that was made was the examination of the secondary attack rate. So the percent of transmission remains in the single digits, but varies with the duration and intensity of the contact. So according to case studies cited in the article, the risk is highest among household members who are 10 to 40% likely to get infected if they reside with a member that's infected with SARS-CoV-2, followed by healthcare workers who also treat infected patients. And there was, one of the main reasons why I chose this article was that there was criticism by other healthcare workers under the article that mentioned how they criticized the presentation of the secondary attack rate statistics because they are quite circumstantial. And one healthcare worker brought up how even in well-ventilated places, there were many documented cases of super spreader, so rapid fire spread of SARS-CoV-2 in well-ventilated places that point to airborne transmission. So lastly, the main thing in this debate is that it's very difficult to simulate aerosol and droplet behavior because you require very specific parameters that must be put in place. And most of the existing literature attempts to hypothesize about SARS-CoV-2 by bringing up case studies of other respiratory viruses, especially coronaviruses. And while they try to establish similarity in behavior in terms of how they behave airborne, the existing literature and clinical studies are few and far in between, and even then, those are quite circumstantial. So that concludes my part of the presentation. Does anyone have any questions or comments? Okay, let me stop screen sharing.
Good job, Amanda.
Thank you.
And Yeji. And I think next we'll move on. Ashley or Catherine, who wants to go next?
I'll go next. So thank you, Amanda and Yeji, for giving such a detailed information about the debate. And actually, Amanda's last article is a good segue for my article, because my article argues more for the consideration of aerosol transmission for SARS-CoV-2 and public health. And so the study examined the evidence for the virus transmission through aerosol and concluded that the claim is supported through mostly three reasonings. So the first one being cases of asymptomatic or pre-symptomatic patients transmitting the virus to other people. Two, some studies have recorded aerosolized SARS-CoV-2 particles that have stayed in the air for an extended period. And three, other viruses similar to SARS-CoV-2 have been recorded with aerosol transmission. And so for the first argument, that there are transmission of SARS-CoV-2 from asymptomatic people. So there are many cases, as Amanda has previously mentioned, that there are many cases where asymptomatic or pre-symptomatic people have transmitted the disease to a mass number of people around them. Perhaps one of the most known instances, the article gave a lot of instances, but in more related to USA would be like the Skagit Valley choral rehearsal in Mount Vernon, Washington. Although later on the interview revealed that the attendees were not symptomatic and were minimizing contact by keeping their distance, 45 out of 60 attendees were later tested positive for the virus after the rehearsal. And so such cases leads questions as to how the disease was transmitted, as many asymptomatic or pre-symptomatic people do not exhibit the symptoms necessary to propel larger droplets to reach a mass number of people, such as coughing or sneezing. However, if the aerosol pathway is considered, it can lead to some insight, as many studies support that aerosol droplets are associated with normal breathing and talking and occasional coughing of healthy individuals. And so going on to the second argument, there are some studies of aerosolized SARS-CoV-2 particles, and although they are limited and restricted to medical and laboratory settings, they have shown that SARS-CoV-2 can linger in the air and travel long distances. So for example, a hospital study found that in patient rooms where COVID-19 patients were being treated and in nearby hallways, viral RNA can be found in the air. And a similar result was found in front of the hospital entrance in another study, although the study did note that it might be from other asymptomatic or pre-symptomatic people that may have passed by during that time. Another laboratory study had found that aerosolized SARS-CoV-2 particles can remain viable for at least 3 hours. And in this case, it says at least 3 hours, mostly because the study itself only lasted for 3 hours. And so throughout the study, the aerosolized SARS-CoV-2 remained viable, meaning that it remained able to infect other people. And so for the third argument, the aerosol transmission of other viruses. So as Amanda had previously mentioned, that there were measles were well known for being able to transmit through aerosol. And so aerosol transmission is an important exposure pathway for infectious agents such as influenza and other viruses, including coronavirus. However, the potential for infection can be varied based on the function of those and the individual's immune response. And Yeji had mentioned also that the ways of dispersion can be affected by the relative humidity, temperature, and other environmental factors. Another study had found that the sizes of the particles can affect the level of infiltration the viruses have when it enters the body, which Amanda had also previously mentioned about how the smaller the particles, the easier they are to reach the alveoli. And in that study, chickenpox and measles were given as examples of lipid-enveloped viruses like SARS-CoV-2, and have strong evidence for the transmissibility via airborne routes. And that will conclude my part of the presentation. So does anyone have some questions at the moment? Okay. Also, sorry, I forgot to self-introduce. I'm Catherine Kung, and I'm a rising junior from Smith College. And thank you.
Thanks, Catherine. I think we'll move along to Ashley's presentation, and then we'll maybe discuss at the end if anybody has questions.
Yep, so I'm going to share my screen now. Okay, so hopefully everyone can see it. So I did 2 papers this week, one on aerosol ability and on turbulent. So, oops. The authors of this study assessed the stability of SARS-CoV-2 and the original SARS as well in aerosols and also on various surfaces. Okay. Zoom in. Okay, so decay rates, this is the method section. Decay rates were estimated using Bayesian regression model, using the 2 different versions for the viruses, and this was found in a previous study. And aerosols containing 105.25 50% tissue culture infectious dose, or TCID 50 per milliliter of SARS-CoV-2, or 106.75 to 7.00 for TCID 50 per milliliter of SARS-CoV-1, the original SARS, were produced with a 3-jet collision nebulizer. The samples were inserted into a Goldberg drum to produce an aerosolized environment. The study design also incorporated 5 different environmental conditions. So these are the surfaces, and they included aerosol, copper, and cardboard. And I apologize in advance. I've gotten a warning. Sure if it's blurry on anybody's end. So, done the results by aerosol results versus stability, or I'm sorry, surface stability. So SARS-CoV-2 was viable in aerosols throughout the entire 3-hour study. Catherine again just referenced that our timeline. So there had been a pre-established timeline for the new infection.
I think maybe we've lost Ashley. Can anybody else hear me?
Yes, we can hear you.
I hear you, Ryan.
All right, I think we've lost Ashley. So, what do we think about aerosol v droplets? I don't think the debate is resolved.
The debate will not be resolved because it's unresolvable.
Because it's not, because it's a distinction without a difference?
No, it really it has implications, but the problem is that both are involved in transmission, and under certain circumstances, there are aerosols, and in most circumstances, there's not a whole lot of aerosol. And every time they try to do something, experiment to demonstrate how much, they get mixed results. And we know by anecdotes that there are, it's sort of like super spreaders. You know it after the fact.
Yeah.
My question reading all of these too was, is there a sense, it just seemed kind of contrived, like the whole argument in most of these papers, like there's a debate and one is more prominent than the other, and it's like, why can't it just be both are happening? I mean, it seems like droplets
That's
probably
exactly it. Both are happening.
Well, that's the thing, and it's like, why? That's why I like the JAMA editorial that was saying essentially the point of it might be spreading aerosol. It seems predominantly through droplets, but to make the argument that like, oh, masks aren't doing anything anymore if it's aerosolized, it's like, well, it's still spreading by droplets. So it seems like a silly argument to have. It's more just a recognition that it's spreading aerosol.
During the 2009 pandemic, there was a recommendation in place from CDC, because they thought it was going to be an avian lethal virus and not the 2009 H1N1, that N95 masks had to be used in hospitals on the basis of having aerosols. And the whole country ran out of the N95 masks. The CDC asked for a meeting at the national academies to resolve it, and they got in aerobiologists who refused to resolve it for them. So they continued to have the situation where nobody was using N95s, but the recommendation was to use N95s. As a result of this, CDC commissioned an extensive study in the UK where they could infect people with flu virus, and they infected donors and used various devices to prevent transmissions to recipients who were in close contact in rooms that were properly monitored in terms of temperature and the rest. And they got no transmission of anything at about $12 million. And I happened to be chair of the external advisory committee, and I got a couple of trips to England. What was interesting is they also had aerobiologists, including the one who is very prominent in this, Don Milton, with his Gesundheit machine, and he is able to monitor what's in exhaled air. And there are viruses in exhaled air of that are small droplets. But the question is, what's going on a regular basis? And a lot of this held back the recommendation for using surgical masks extensively, because surgical masks don't hold back aerosols very well. And that was the reason Tony Fauci didn't say use surgical masks early, which he's now being called on the carpet about. So it's a question that really can't be answered except in experiments of nature, where you use one or the other or both, and you try to see what the effect is. And I think up to now, we see the surgical masks do seem to be working. Healthcare workers at university hospital, unless they're in aerosol generating procedures, are using surgical masks.
I guess my question then, after reading all of these, was especially with the paper that was in the environmental research one that had all the droplet diagrams of people standing, people sitting in airplanes, people sitting in a car and in the dorm, like the hospitalized room. It's almost like, does something so engineer focused on the dynamics, is that almost a disservice to the public health effort? Because the conclusion coming away from this is, oh, it seems like no one really knows, and so aerosolize, we probably don't need to, either it's happening or it's not happening, or one's more important than the other, and so we should focus all of our efforts on, I thought the airplane diagram was goofy, where the guy coughs and it only travels forward and backward from him. Like, that just seems ridiculous. There's so many little complex factors.
There's a famous, everything in flu used to be anecdotes until the aerobiologists got going and until PCR made it easy to identify RNA. But we still don't know if it's replicating virus. And the famous outbreak was one in which a plane in the winter in Alaska during the flu season got stuck on the tarmac. They couldn't take off for a number of hours. They turned off the air handling system, and everybody on the plane got infected. So the argument was, this demonstrates there is aerosol transmission, because it should have only spread within 3 to 6 feet of the passenger. And then they started looking at it, and this is and there are schools of thought that emphasize one and the other, and careers dependent on aerosol transmission. And they discovered that people had moved around on the plane. There's submarine outbreaks. There are all sorts of things. A lot of
the person in the seat coughs to his side instead of forward, and it kind of spits in the face of all these aerodynamic fluid models. They're only as useful as, exactly that one situation they're proposing.
Yeah.
Nice pun, Peter.
Thank you.
But where we are on policy now has in some ways been undermined by the aerosol argument that says that it shouldn't work. The only other solution in this country is N95 masks. And every time N95 masks don't work, they say they weren't fitted right. So my take on this is, you can't win in this argument. There's both, and you have to decide based on risk and logistics and the rest, what you're going to try to interrupt. What I think is interesting, though, is, well, just to back up, what is the evidence, which seems to be stated all the time, that surgical masks are better in protecting the environment from the infected than the other way around?
I think it's Don's studies where they put people in a surgical mask and then had them talk or sing into that Gesundheit machine and showed that there was substantial reduction of virus emitted. But they're small, relatively small studies.
Yeah, but why not the other way?
Yeah, I think they're saying like, okay, look, there's this evidence for source control, but there's more limited evidence for.
Yeah, but the
Yes,
probability of if this is having an effect, which it seems to be having, the probability of mass preventing transmission from a person who is infected is much lower than the probability of protecting the world from the occasional person who is infected.
Yeah.
Because the likelihood of a person actually being infected and going out there and infecting everybody is low in terms of and the other thing, which is
I mean, one person can only contact so many other people.
so
right?
many individuals. Exactly. The unidirectional protection. But the trouble then becomes that in this political environment, all this controversy is used to say there's no good scientific evidence that physical or face covering works because of airborne transmission. And that's what we're dealing with for those who go as far as science to explain their recommendations.
Yeah. Yeah, I think that's right. And I mean, it's the smaller particles are able to pass through a surgical mask, but how often do they? Because people are, you're not standing still and just getting sprayed in the face with aerosol. You're moving around.
There are a lot of other things that go on, including closeness of contact, period of
duration, yeah.
And it is very clear there is airborne aerosol transmission. This whole business of involving our knots in it's really a stretch.
But so you don't buy the argument that if it was predominantly airborne, it would have a higher R naught?
Yeah, I would, but that I think is true. I think that, and we know that that measles has got to have a high R naught.
Yeah.
Tuberculosis does too. Tuberculosis is documented.
Right.
Even though, but with tuberculosis, we don't see massive spread because there's also some degree of immunity in the populations where the disease is prevalent.
Mm-hmm.
With this, you got a virgin population and super spreaders. But what can be the take-home message about the face mask? What we can say for sure is what particles get through and what can't get through. And I think that's interesting. And what about all the homemade masks versus surgical masks? Yeah.
Well, you get into so much variability with the homemade masks. I'm not sure. I mean, you said it's hard to do with the surgical masks, and those are standardized. If you're trying to do it with the variability, the level of different materials plus adding filters, subtracting filters. I mean, it's. Are we
doing harm or good by recommending that people do this? I don't think we're doing any harm. Are we doing good?
Yeah, I don't think we're doing any harm either. I don't know. It probably helps with some of the larger droplets.
Yeah, that if you've gone through training for COVID training, one of the things they show is the candle. And if you're wearing a face covering, you can't blow out a candle.
Yeah, I saw Bill Nye doing that on Twitter.
And what does that have to do with droplets?
I don't know. Probably nothing. It's that's a tough call. I mean, I think obviously the preferable situation would have been sufficient supply of surgical masks. But I think one thing this does do is
it's aerosols. surgical masks don't work all that well.
Yeah.
That's the trouble. I think I don't know that we'll come out of this pandemic with any better knowledge than we did coming out of the flu pandemic in 2009.
Do you think that just the act of normalizing mask wearing is beneficial?
Well, there are studies, but they're all like ecologic, which say that if you wear face masks, you have less transmission.
Yeah.
And I don't know if the group has looked at what you read about, why, when the question is made, why did you change your recommendation and start recommending face masks, surgical face, or the equivalent face mask? What has been the accumulating information? I'm not clear about that.
I mean, yeah, it was, I think there was, sort of the ecologic, and they weren't even, published papers, but just sort of the ecologic analyses of, countries where they're more likely to wear, face masks universally with lower spread. I mean, and obviously those aren't perfect correlations, but it's got to be mostly based on that they made the recommendation.
Now, what do we do if we believe there is significant aerosol transmission? Like if you're in a meat packing plant, I think there are air purification measures, because one of the things you can consider is trying to identify where it's more likely to occur when people are in close contact over long periods of time and there's not good air handling. And what we
But again, even the air handlings would be to mitigate the aerosolized transmission. And
yeah, where
I don't know. It's even like if the argument settles on 30% of transmission, eventually we find out 10 years down the line is through droplet transmission, but masks still reduce that by isn't doing anything like better than nothing in a way. Isn't wearing masks to prevent that fraction of transmission beneficial?
Large droplets. Now aerosols.
Yeah, that's what I mean though. If you're preventing that large droplet transmission, and then the large droplet via fomite transmission or something,
Yeah.
Isn't that good in a way?
Yeah, exactly. At least because I think what's happening is they've looked at these massive outbreaks. By massive, I mean large percent of those in contact, and they say the only way to explain this is significant airborne aerosol transmission. You have to watch out for the use of airborne, because to me that can mean anything. It's aerosol or a large droplet. And I was contacted early during the pandemic. There are companies that manufacture UV light kind of air decontamination who wanted to set up studies. And it's almost impossible to set up studies, but they may want to do the places to do that are where there's a suspicion of that there could be aerosol transmission, because people are in close contact over long periods of time. The problem there is if they're in close contact, like in a meat packing plant, you also facilitate large droplets.
We have an identifiability problem. We need
Yeah.
MRSA.
See, what you really need to get involved is not just the aerobiologists, but those who have issues with the built environment, as they put it.
Yeah.
Because those people might have something to contribute here. In fact, the reality is that if you acknowledge there's an airborne aerosol transmission. What do you do about it on a population basis?
Stay outside.
Yeah.
All right. Well, that was a good discussion.
No
I don't-
solution. This has been going on for years. You know, the Hong Kong group got they had a 3-year grant from the Hong Kong government for transmission.
Yeah, I
And
know they worked with. I think they worked with Don, didn't they?
that's why they worked with Don. And I don't know that they've got any real answers.
Well, they published that thing in Nature Communications earlier this year about with face masks preventing emission of flu and seasonal coronavirus.
Yeah, but the trouble is, it's so hard to generalize.
I know, and the numbers are very small.
Very small, and they're kind of stunts more than contributions to knowledge.
And I mean, they have people in those Gesundheit machines for a half an hour. It's But anyway, well, good. Once again, we haven't answered any of the questions that we set out to answer.
But with this virus, you rarely do.
But with this virus, we rarely do. We are going to I recorded this session and we're going to make it available on One Academy's YouTube channel so that future students can see how to present these
I think
sorts
the
of summaries.
presentations were great.
I think so too. Yeah, everybody did a really nice job. So thank you to all of our presenters. And unless anybody has an objection, we'll go ahead and put that on the YouTube channel so that people can see how these tend to go. If you do have an objection, I guess send it to me or Iman via email, and we'll figure out what to do about that. Maybe make it private or something like that. So thanks again, everybody, for the discussion and for the presentations, and we will see you all next week.
Have a good weekend, everybody.
Have a good weekend.
It's going to be hot.
Thank you.